Now. Um, we are continuing our trauma module, and we're going to be working on the face and neck injuries. So this is a small area, but there's a lot of stuff going on here, right? Face and neck are particularly vulnerable to injury because of their relatively unprotected positions of the body. If you think about it, you have your skull that protects your brain, but everything else about your head is on the outside. Your eyes open directly to the outside, your nose is directly to the outside, your mouth is a um, it's unprotected for the most part. Your trachea and your neck is front and center. So the only thing that can protect it is A, if you manage to get your hands in place in time, or B, if your chin gets in the way. So a lot of times when we're dealing with the kind of trauma, the kind of injuries that you're going to get called for 911, these injuries are not just, something mild hitting somebody in the face. This is usually a steering wheel or a tree branch or something of that sort. Soft tissue injuries and fractures are common and vary in severity, and some injuries are life-threatening because, again, what's the big thing that's in this area? What's one of your biggest issues if you think about your primary assessment? Your airway, exactly. It's a wide open spot. That's one of the biggest issues. If you get popped in the neck or you get hit in the face, say you get some massive trauma to your nose and mouth, you break off teeth, now you run the risk of choking on them, which we're going to talk about tonight. These are the kind of things that can threaten your life. Yes, I talk about the face being highly vascular, so a little small cut may look like a murder scene, and that's not something you really need to worry about. It's just a lot of the blood's not that bad. It's just surprisingly a lot for that injury. However, when it comes to their airway and breathing, that's your biggest concern as far as your primary is concerned with these kind of injuries. If a hematoma forms in the area, it may stop blood or slow the blood flow to the brain. We're going to talk about that a little bit as well, this can cause a stroke. You also have the air embolism, as you can see right there, if there's penetrating trauma to the neck. So we worry about a whole lot of things, a whole lot of serious things in a very small area, as you can see. Um, the hematoma, we'll talk about that a little bit more later. The thing about it is that you don't have a lot of room. Your skull is unforgiving. If you get a swell on the outside, great. You're lucky. If it's a swell on the inside, though, that causes a lot of other issues. With appropriate pre-hospital and hospital care, a patient with a seemingly devastating injury can have a surprisingly good outcome. So that is one of the things about this. You and usually with the help of a paramedic, depending on how bad the airway is, um, y'all can make a major difference in the outcome of the patient. So a real quick anatomy review. The head is divided into the following. I'm going to start with the cranium. This is basically the top, back, and sides of your skull that protect the brain. The brain connects to the spinal cord through the foramen magnum, which is just a giant hole at the base of the skull, and a large opening at the base. Or I'm sorry, that is a large opening at the base. Um, the only real thing that you need to know about that is if they get hit in such a way that their C1, C2 vertebrae get knocked out of alignment, that can put pressure on the cord in a very bad spot. If that area gets severed or pinched, that shuts down their actual body processes like their heartbeat, their ability to breathe, and then your patient's going to die. It's not an injury at that level um, is a massive, massive problem. It's not like if they took a thoracic or a lumbar spinal injury and then they lost feeling in their legs. You can survive and not feel your legs, but if you have a problem at the C1, C2 spot up there at the very top of the neck, you're cutting off your autonomous system. All right, so breaking your cranium apart, the most posterior portion of the cranium is called the occiput. So think occipital lobe. It's on the back of your head. On each side and the lateral portions, these are called the temples or temporal regions. So if you've ever heard somebody say that they've been hit in the temple, they're really talking about kind of to the outside of the eye, their eye level, between your eyes and the top of your ear. You can feel that relatively soft spot. The skull is still a solid piece there, but it's concave and it goes in, and a lot of your muscles attach right there. It's a very vascular, very um, muscle and vascular rich area, so it's soft, it's tender. If you press on it even just a little bit, it'll hurt. Like it'll make your eyes hurt. It'll give you a headache after a while. So I don't recommend doing it, but you get the point. It's where a lot of different facial muscles kind of connect and attach. Between the temporal regions and the occiput lies the parietal regions. The forehead is called the frontal region, front of the head. Anterior to your ear, in the temporal region, you can feel the pulse of the superficial temporal artery. Usually, we don't check there for a pulse. That's not something you're normally going to do in class, but you can find it there. There's an artery that runs through there. Your face is composed of your eyes, ears, nose, mouth, and cheeks. If you ever hear anything about the buccal region, they're referring to the cheeks. You may see it referred to as that, rather than actually saying cheeks. Cheeks is more of a layperson term. It's what we use when we're just having a conversation. The six major bones of your face, as you can see here in the picture, that word is buccal, B-U-C-C-A-L. I would spell it, but I can't see my cursor when I'm in full screen like this. Yeah, well, some medications are given. You'll hear it said they are given in the buccal area, which means that you put it in the cheek on the inside of the mouth, just because it's highly vascular there and it absorbs easy. Six major bones of your face. You have your nasal bone, which if you think about your nose, if you feel the top center just a little bit above halfway, you'll feel where the hard spot starts and then it runs up the rest of the way of your nose. And then that whole soft portion, that's actually cartilage. Your whole bone, your nasal bone, only goes about halfway down the length of your nose. You have two zygomas, two maxillae, and a mandible. So your zygoma, those form the bottom of your eye, and they kind of come around and they form your cheekbones. So the zygomatic arch is actually your cheekbones. Your maxilla, even though it's the upper half of your mouth, it's two bones that are fused together, and then your mandible. The only thing you need to know about your mandible is that that's your jaw, and it's the only movable bone in the entire cranium, the entire face. All of that stuff is fused together. It doesn't move. If it does, that's a problem. But your mandible, which is your jaw, that is designed for motion. Everything else is fused into place. The bony orbit protects the eye from injury. There's a couple different bones that make up that orbit. It's not just one solid ring, but only the proximal third of the nose is formed by bone. We already mentioned that. Let's see. The exposed portion of the ear. Let me get to the right thing here. There we go. The exposed portion of the ear is composed entirely of cartilage covered by skin. There's no bones for the ear as far as what we consider the ear. That's all cartilage. The external visible part is called the pinna, and the tragus is a small, rounded, fleshy bulge immediately anterior to the ear. So if you, the little part that kind of folds, so it's harder cartilage and it points back toward the loop of your ear, that's your tragus. Superficial temporal artery can be palpated just anterior to the tragus, so right in front of the ear. You should feel it. If you put your finger right where the tragus comes off the side of the face, off the side of the head, you'll feel it. It's almost on the ear, and you only need one finger to feel it. If you were to put up, like, say, your middle and your index finger, your middle finger is going to be too far forward. It's going to be pressing on your zygomatic arch, and you won't feel it. About 1 inch posterior to the external opening of the ear is the mastoid process. This is a bony mass at the base of the skull, and that's going to be where your jaw connects. The mandible forms the jaw and the chin. The jaw is the lower border of the mouth, as we all know. The tongue and 32 teeth are located on that. The motion of the mandible occurs at the temporomandibular joint, which, if you can look on this picture, you see where it points to it. All it is just a little process that just sticks in there. And then the muscles that run underneath your jaw are what pull down, and it just levers on that. The only thing I really want you to know with this, I mean, this quickly becomes an anatomy class, but as far as injuries are concerned, if anybody's ever dislocated their jaw, what's happening is that temporomandibular joint is getting popped out of place. So when that happens, now you have what was essentially a lever, is the fulcrum has been pushed out of the way. So you have that where, depending on how it came dislocated, your jaw may be just pushed to the side and wedged up. Your jaw, the patient, not yours, but the jaw's patient, the patient's jaw could be hanging down and they can't close their mouth. Um, you may see it present in a couple of different ways. It just depends on what, how did it move out of that socket and where did it go. But when it's in place, that's how the jaw actually moves. All right, for your neck, we have a couple of important structures here, and we've talked about it before when we talk about our assessment. Remember, I want you to think you're going to check the front, the sides, and the back of your neck, because what you're doing is you're checking the main things. So we'll hit these a little bit. Your neck is the spine that's in your neck is your cervical spine. That's why we call them C collars. When you put a C collar on, it stands for cervical collar. The first 7 vertebrae, so C1 through C7, are going to be your cervical spine. C1 is called the atlas because it's basically that's the spinal the vertebrae that holds the skull, right? So if you think about the picture of the guy that's holding the planet on his back, and his name was Atlas, that's what they call that, C1. C1 is where the brainstem or the cord, I'm sorry, that's where the cord starts. Right above that is the brainstem. So if there's any bone dislocation there, you run the risk again, like I was saying earlier, you're cutting off autonomous body systems. So their heart will stop getting impulses from the brain, the blood vessels, that all that stuff is going to lose connection, and then they're pretty much dead at that point. You're going to be doing CPR until a neurologist can get in there and fix them, and usually they don't make it. That's not something that the doctors expect you to do. The spinal cord exits from the foramen magnum at the base of the skull and lies within the spinal canal formed by the vertebrae. It goes all the way down almost to your butt. The upper portion of the esophagus and the trachea lie in the midline of the neck. So what you're looking at when you look at the front center of somebody's neck is actually their trachea. That's their airway. The esophagus runs down behind it between the trachea and the spine. So a lot of times, at least as far as trauma is concerned, the esophagus really doesn't get hurt. Not unless something's like being shoved down their throat. Usually the airway will get hurt or the spine will get hurt depending on how they got hit. Because remember, your airway it's got cartilage that forms a rigid, keeps the airway from collapsing when we breathe, but it actually has some protective value to it as well, both for itself as well as the esophagus behind it. The carotid arteries are found on either side of the trachea. That's how we feel when we're feeling somebody's pulse in their neck. You just go to the side of the trachea and you'll feel it. Your jugular veins are there as well. Now, if you've never seen the jugular veins, don't get them mistaken with the muscles that run along the side of the neck. A lot of people like to I've noticed students in the past will point at the musculature and say, that looks pretty big. Is that JVD? I'm like, no, that's a muscle. That's not the vein. Uh, the vein runs along the outside of it. Usually you can't see it unless it starts to swell a little bit. If you get what's called JVD, your jugular vein distension is massive, and you'll see it. It looks like a hematoma or a water balloon sitting under the skin on the sides of the neck. But for your larynx, this is your airway that you can see in the neck. So the Adam's apple is located in the center of the anterior of the neck. The Adam's apple is the upper part of the larynx. It's formed by the thyroid cartilage. So if you look at this picture, when it says thyroid on the left and it's pointing there, that's that top half of the cartilage right there, and then underneath it you have the cricoid. That protects your cords. Those two cartilage areas are pretty tough. That's why, like, if you're poking on your neck or whatever, um, you'll notice that cartilage doesn't give. It's not like your nose, how you can move your nose around. Your cartilage around that area doesn't. It takes a lot more effort to do it because they're actually meant to be protection, whereas your nose is just meant to be some form. Um, The big thing about those landmarks is some paramedics, if you're assisting with them giving an ET tube, they may ask you for crike pressure. If you've ever heard of that term, or cricoid pressure, you're going to take your thumb and your index finger, place it right below the Adam's apple, and you're going to press straight down like you're pushing toward their spine. And what that does is, if you think about the shape of not your epiglottis, I'm sorry. If you think about the shape of your cords, they're like a football. And when you press down on that, you're basically pressing on the tips and you're opening it up so that your paramedic can get a better view and an easier time actually getting his tube through the cords. Because some people, their cords are very close together and they don't have a wide opening to work with. And then your cricothyroid membrane is right between the two cartilages. If there's ever a surgical airway that needs to be done, and that's a paramedic thing, that's not us, but that's where they're going to cut. A surgical airway, they just cut that cartilage, that membrane right between the two cartilage, and then they can stick a tube down the throat from there. Stomas are placed there. So if you ever have a patient with a stoma, that's going to be where that connection, where it goes through. And remember, if that's the case, that is their airway. It's not their mouth and nose at that point. So if you have to clear something, or you need to bag them, or that sort of thing, it's going to be at that location. If you need to, if let's say you have to bag them and they have a stoma, cover their mouth and nose, because that air is going to go the least resistance, which is going to be right back out the mouth and nose, as opposed to down into the lungs where it's pressurized. All right, I already talked about the cricothyroid. There we go. Okay. So the trachea sits below the larynx. Trachea connects the oropharynx, which is your mouth area, and the larynx with the main passages of the lungs. On either side of the lower larynx and the upper trachea lies a thyroid gland. So if you remember when you learned about the integumentary system, if you've ever taken an anatomy course or any of that sort, the thyroid, if you've ever heard people talk about their thyroid and everybody swears up and down they have hypothyroidism, the thyroid is in that area. Your sternocleidomastoid muscles, basically, for such a big word, that's just basically saying it's the muscles that connect to your sternum and your cleidomastoid bones. These originate from the mastoid process of the cranium and insert into the medial border of each collarbone. So those are the muscles that run the length of your neck, right? That's what I was saying. That some people mistake when they've never seen a jugular vein or anything like that. I'm not saying it to pick on people, but some people just think that the muscle they're seeing, that's got to be the vein, and it's not. It just runs in the same direction, but the vein typically sits on top of it. Those are the muscles that allow you to move your head. For your eyes, these are globe shaped, approximately 1 inch in diameter, and in most people, the distance between the eyes is the exact same width as the eye itself. So if you were to take somebody's eye, duplicate it as a third one, and put it right in the middle, they would touch each other. Just a little gee whiz thing. It's not always the case. Sometimes they're a little bit closer together, a little bit further apart, depending on genetics. Um, but the average distance is the same. These are located within the bony socket in the skull called the orbit. We talked about those earlier. In adults, the orbit protects over 80% of the eyeball. What you actually see is just a small portion. The eyeball is a lot bigger, as you can see here. The eyeball, or a globe, whichever one you want to call it, keeps its shape as a result of pressure from the fluid contained within its two chambers. Actually, my brother-in-law had an accident at work once a couple years back, and he got hit in the eye, and it popped it like a balloon. All the fluid came out of it, which was horrible. I mean, it made me cringe just hearing about it. And it was a pretty long road to recovery for him. But one of the coolest things, just because I'm a medical nerd, one of the coolest things about it was by the time they got him to the hospital, his eye had already refilled with that viscous fluid. It didn't stay empty. So that's one of the things, that's one of your body's mechanisms to maintain that homeostasis and keep things like they should be. His body realized that one of his eyes had gotten hit and deflated, and it just poured more viscous fluid in there and reinflated it on its own. Now he still had massive damage, like he had to get his cornea and all that stuff fixed. Um, but as far as that, the shape of the eye, the body fixed it on its own, and it did it pretty quick. So there is a clear jelly-like fluid in the back of the eye. It's called the vitreous humor. That's what gives the eye its shape. Because again, these things are basically water balloons. In penetrating injuries, aqueous humor may leak out, but it typically will refill. With time and appropriate medical treatment, the body can make more. Um, it just, I don't know, like I said, for him, it was pretty quick. It was right. It was just a time to get to the hospital. The conjunctiva is a membrane that covers the eye. And then you have your lacrimal glands. These are your tear ducts. So sometimes you may have a patient with a clogged tear duct, and that'll cause some swelling. They may have a bump there, and they don't know what it is. Um, if the tears can't flow properly, I think that's a sty, if I'm not mistaken. If you've ever heard anybody say they had one. Your sclera is the white fibrous tissue that helps maintain the globular shape and protects the more delicate inner structures. In the front of the eye, the sclera is replaced by a clear, transparent membrane called the cornea. This is what allows light to enter your eye. And then you have the iris, which is a circular muscle behind the eye. The iris acts like a camera to adjust the size of the opening. So when your pupils dilate or constrict, it's the cornea that's doing it. I'm sorry, it's the iris that's doing it. And the iris is what gives your eye its color. So that's the color portion of your eye. The pupil is the opening itself. This is what allows light to enter. And with the iris's help, it will grow or shrink so that you get just the right amount of light, and they work together. If you're doing a neuro check on somebody, you shine a light into their left eye, their right eye should react, just like the left one does. Make sure I'm on the right slide. All right. Anisocoria is a condition in which a person is born with different sized pupils. If you show up to somebody with this and you see the different sized pupils, don't immediately jump on a head injury. If it doesn't look like they've got a head injury, but you see that where one's dilated, one's constricted, just ask them. Be like, is that normal for you? Because for some people it is. It doesn't necessarily mean that they have that head injury, even though it's a telltale sign. But that being said, if they're unconscious, then err on the side of caution. If you see that, yeah, it could be that condition, but don't let that stop you from doing the right treatment just in case they did get a head injury. All right, so your lens lies behind the iris. The lens focuses images on the retina at the back of the globe. If something goes wrong with the lens, or if there's, say, like a patient has glaucoma, where light can't hit the lens properly, that's going to make their vision be out of focus. The retina covers nerve endings which respond to light by transmitting nerve impulses through the optic nerve to the brain. And the interesting thing about that is your optic nerve actually runs all the way to the back of your brain. The occipital lobe, which is the back of your brain, the back of your head, that's actually where your vision is processed. So you would think that because your eyes are in the front of your head and the shortest distance, the front of your brain would be what processes your vision. It's not. Um, if a patient gets hit in the back of the head, one of your major questions to them would be, did you lose vision? Because that's a sign that they got hit hard enough that they probably took some damage to their brain. Um, and we'll talk, well, not in this particular lecture, but I may throw it into your boot camps. We'll talk about some different parts of the brain and where they're located, so that when you're dealing with trauma, based on what your patient's doing in front of you, you can kind of get an idea of where the problem is in their head. I may bring it up when we do TBIs. We'll see. All right. So for the different injuries of the head and neck, injuries about the face and neck can often lead to partial or complete obstruction of the upper airway, and this again is your main concern. Don't let the blood that you might see be your distractor unless it's getting into their airway. But again, that's your concern. Several factors may contribute to the obstruction. So blood clots in the upper airway, um, This can lead to complete obstruction, especially in unconscious patients, because they don't have that ability to clear their airway. Direct injuries to the nose, mouth, and the larynx and the trachea are often the source of significant bleeding and or respiratory compromise. So if you're going to get blood in the airway, getting injured right there is pretty much the best way to do it, because that is the airway. The blood's only going to go um, deeper into the airway from there. So if you have a patient with facial injuries, get your suction. Make sure you have it on hand, even if they don't have a compromised airway yet. If they start to lose consciousness on you, they're gonna get it. So have your suction there ready to go. Just be proactive with that. Injuries may cause teeth or dentures to become dislodged into the throat, um, especially if they get popped in the mouth. The airway may also be affected when the patient's head is turned to the side. This is often the case if they have an altered level of consciousness or if they are just straight up unconscious. Possible injuries to the brain, sometimes the cervical spine may interfere with normal respirations. If they get hit in that area, if it's bad enough to affect the brain at about the mouth level, that if you think about what's there, that's the base of the skull, right? So again, we're talking about that brainstem area, C1, um, base of the skull. You're going to shut off or compromise their ability to breathe, because that's an autonomous body process. In fact, if I don't know if I've mentioned it to you before, and I try not to do war stories, but I bring them up from time to time. There was that one patient that was in the car wreck. She gets out, and we're trying to talk her into being still, and she's like, "No, I'm fine. Look," and she did her head from side to side, and the next thing you know, she's on the ground unconscious and she's not breathing. That was why. She didn't realize that she actually had, we talk about step off, where one of your spinal vertebrae pops out of place. She didn't realize that her C1 had slid out. Um, and when she tried to move her head, it just slipped out of place, pinched her spine, and then that was it. That was all she wrote. So if these are the injuries that you've got, even if your patient doesn't really, if they're awake and they don't think they're that injured, just err on the side of caution. They definitely need a C-collar when they're hitting this area. Soft tissue injuries of the face and neck are very common. Again, when we're dealing with the skin, we don't have a lot of protection up there. Not only that, but if you think about the size of your head, the weight of your head on your neck is almost like a bobblehead. If y'all have ever seen those toys where you kind of flick the head and they bobble for a while, we're not that bad, but it's just we're not built for protection of our head for anything outside the skull. The skull protects the brain, but everything else, like your mouth, your nose, and all that, they are completely unprotected for the most part. It's very easy to take serious injuries there, and your skin, for as vascular as it is, because our facial expressions are a key to our ability to communicate. Um, these injuries can look really, really bad, and they can be the most unsettling too. You see somebody with a messed up face, um, it can be just as mentally stressful on you as if they had lost an arm or had an evisceration or something of that sort, because we use our face for communication. The face and neck are extremely vascular. Um, if you've ever shaved and cut yourself, you know that the smallest little nick can look like a murder scene. Swelling in the area may become severe if the bleeding can't get out of the skin properly. Skin and tissues in these areas can produce some really heavy bleeding, even just small ones. And then a blunt injury can cause a hematoma, which is where the blood starts to pool up under the skin and create a swelling spot right there. Because again, it can't go in. It's not supposed to go in because the skull is there. So it should be coming out. Mandible injuries are common because of its prominence. Secondly, only to nasal fractures and frequency. So a lot of times you're going to deal with people who have hurt their jaw in some way or another. Again, if you remember that picture, it sits in place with just that tiny little fossa, that tiny little process that sticks up into the skull. The rest of it is just controlled by muscle to move it. So it's very easy if you think about it. There's not a lot keeping it in place. Signs of a mandible fracture can include misalignment of teeth, numbness of the chin. So if they can't feel their chin, because they probably pinched off the nerve that runs along there, and an inability to open the mouth. Again, depending on how they fractured it or how they knocked it out of place, they may not be able to open their mouth. They may not be able to close their mouth. It just kind of depends on what you're looking at. But regardless, they're not going to have good function of it. They whatever it is, they won't be able to do the opposite. Maxillary fractures are usually found after blunt force, high energy impact. So if somebody smacks the windshield, smacks their steering wheel, that's where you're going to see these. Some signs include massive facial swelling, instability of the facial bones, and misalignment of teeth. So that instability of the facial bones, if you've ever in your studies or if you've ever worked with somebody and they talk about what's called Lefort fractures, and I used to give this out as a writing assignment to people, but there's three different Lefort fractures. You have 1, 2, and 3, and that is where the break happened on the face. Lefort 1 being the least worrisome, I'll say, the least severe, and the higher the number, the worse it is. The higher the number, the higher the fracture is, to the point where the highest Lefort fracture is you could actually like grab somebody's face and remove it from their skull. Like you can grab their whole face, cheekbones and all, and it moves independent of the rest of their head. It's trippy. Um, but that's what's happened is you've broken the bones that constitute their face. Fractured and divulged teeth are common following facial trauma, and teeth fragments can become an airway obstruction and should be removed immediately. So suction, right? All right, for your patient assessment, um, just like normal, you're going to go through your patient assessment, starting with your scene size up, which begins with what?
Scene safety.
BSI, scene safety. All right. So you're going to make sure the scene is safe for you. And you're going to actually look around, paint your picture, look for hazards and threats, mitigate what you can. Make sure you're wearing your own PPE. If you're going to deal with something like a facial trauma or facial trauma, neck trauma, that kind of thing, the bleeding can be so bad. You're probably going to want to swap out your gloves. So carry some extra gloves. Determine your number of patients if you need additional resources, that sort of thing. Check out your mechanism of injury, figure out what might have done it. So if you show up to a car wreck and you see that the top third of the steering wheel is bent over into the dash, you know that's probably where you hit. Um, and then like it says here on the slide, some common MOI for face neck injuries. You have your motor vehicle collisions, sports, falls, trauma, penetrating and blunt. It can be either one. When you get to your primary assessment, that's your life threats. So focus on your ABCs, get their LOC, their level of consciousness. Hopefully they're alert. If they're not, then you're going to have to take care of some things for them, like their airway, possibly their breathing. When there's a life-threatening external hemorrhage, it should be addressed before your airway and breathing. So they are putting that in, which is nice. Because in trauma, again, it's one having somebody's airway doesn't mean anything if they have no blood left to circulate the oxygen. But again, that's only in hemorrhaging. When you're dealing with this area, you're really not concerned about an external hemorrhage that you need to address at this point. Mostly what you're worried about is your airway. But if they got hit in the head, they could have got hit somewhere else. So just do a quick scan head to toe. If you see them pooling out blood or spurting it across the room, that kind of thing, take care of that. Then do your ABCs. Form your general impression. Look for important indicators of the seriousness of the patient's condition, usually at this point by their level of consciousness. Injuries to the face and throat may be obvious, but may also be hidden by collars or hats, depending on what they're wearing. It could be, it may be a football player, a motorcycle rider. They've got a helmet on. Some of these things can kind of cover up what's going on with them. Control your blood loss with direct pressure. Use a tourniquet if you need to. For the head and neck, obviously, direct pressure is all you got. Consider the need for manual spine stabilization and check for your responsiveness. Ensure their airway is clear. If they have any kind of trauma around the face, you want to make sure that you have your suction on you. If we're giving you a scenario, typically we drive that point home because I'm going to make you have to suction your patient every time that this injury is apparent, because I want you to know how likely it is, how much of a threat it is that their airway is going to be compromised based on whatever it is that they're bleeding, or they've punctured, they either punctured their airway, or they got hit in the neck bad enough to cause it to swell, um, that kind of thing. If the patient's unresponsive or has significantly altered level of consciousness, consider an appropriately sized OPA. The OPA is my favorite. It's the best of the little airway adjuncts. However, if they're not completely unconscious, they're not going to take it. They're going to gag on it, and then you have to remove it and go to your NPA. Just be careful with the NPA. There's a lot of back and forth on it, because if they got hit in the face, especially between the chin and the nose, there's always that risk that they fractured their hard palate or their cribriform plate, and the sorry, the powers that be that determine how we operate keep going back and forth over whether or not it's safe to put an NPA up somebody's nose, because there's always that chance that you might push it into the brain cavity. Um, as it stands right now, they're saying don't be afraid to do it if you need to, because it's a pretty low chance, even though it is a chance. But if you don't have to do it, if the airway is okay, or you have another option, use another option. Follow your local protocols, because they may say something different. Palpate your chest wall, and um, at this point for your primary, I don't want you looking for decap BTLS. That's part of your head to toe in your secondary assessment. When you're dealing with your airway and breathing, I do want you to check the chest wall though for your flail segments and your sucking chest wounds, because those are direct impacts on their breathing. Right, but if they've got abrasions and some tenderness in the chest, who freaking cares at this point, right? We're only worried about their life threats. So I don't want you getting hung up on that. In fact, because that's part of your head to toe, by the assessments, that would fail you. So make sure that you're not doing that too soon. Save that acronym for when you do your head to toe. Splinting or otherwise restricting chest wall motion is contraindicated. You don't want to make it any harder for them to breathe than it already is. Splinting is ineffective and it can impair gas exchange. The reason that people splinted for a while was because of the flail segments. They were trying to stabilize the chest wall, but it wound up causing more problems than good stuff. So we don't do it. For your circulation, get a quick pulse rate and quality. Determine their skin color. You're mainly looking for signs of shock here. So, warm and pink is good. Cool and clammy is bad. It's pretty much all we need to worry about at this point. Check your cap refill time to get your baseline, and any significant bleeding is an immediate life threat. You can take care of that there. Mostly anything bad enough that you think they might not survive if you don't take care of it. So don't worry about if the blood's there already, but it doesn't look like more is being produced, then that's okay. If it's just like a paper cut bleed, then that's okay too. But if it's on the face, that paper cut bleed is going to look like a scene from a horror movie. Make your transport decision. If it compromises their airway, if this is all you're looking at is face and neck, if it compromises the airway, they're a high priority for transport. If it's just some bleeding, maybe some loose teeth, things like that, and they're conscious or whatever, sometimes it's not always going to be a high priority. In the class, yes. In the real world, it really does depend on what's in front of you. Because there will be people that get into fights and have facial trauma here, but because they're low velocity, low impact, fist to the face, unless it's Mike Tyson, they're probably not going to be a high priority for transport. Some signs of hypoperfusion, which is the fancy word for shock, includes tachycardia, tachypnea. Those are your early signs because you're still compensating. If you see low blood pressure, weak pulse, and cool, moist, pale skin, those are your later signs. Those are the pucker factor moments that you need to hurry up and get them to a hospital because they're already pretty far along, and we can't bring them back, so we got to hurry up and get them to the hospital. The patient who has a significant MOI but whose condition appears stable should also be transported promptly. They may not stay stable. If it's a significant MOI, it doesn't really matter what's standing in front of you. So if you see a bent steering wheel, if it's a car wreck, a spider web windshield, no airbag deployment, doesn't look like they're buckled up, but they're up walking around. First of all, they need to stop walking around, but um, don't let that give you a false sense of security. They could be going into shock. They're just still compensating, but the more they walk around, the more they exert themselves, the faster they're going to decomp. Remember that any significant blow to the face or throat should increase your suspicion of a spine or brain injury. If they get hit in the head and it looks like it's just the head, they're very high risk of having a cervical spine issue. If they got hit in the chest, the kind of the same thing. If they get hit both, say something hits them, if they get hit by something massive enough that catches their chest and their head, they actually have a little bit less risk of a C-spine injury. I'm not saying you should rule it out, but if they're both hit, then both body areas are going to move together. So you have less of that whiplash effect. It's a little bit better for the patient, at least in that sense. Even if the patient has no signs of hypoperfusion or other life-threatening injuries, there's always a possibility of eye injuries. And in the military, for example, everybody's always heard life and limb. For us, it's life, limb, and eyesight. They actually included that in there as a life threat or equal to it. So consider it serious. The patient should be transported to the hospital as quick and safe as possible. And surgery or restoration of circulation to the eye will need to be accomplished within 30 minutes, or they may be permanently blind. That's not a long time. If you think about the fact that, first of all, they had to call 911 after getting hurt, then they had to wait for you to get there. Then you had to do your assessment, get them in the truck, get them in the hospital. 30 minutes to surgery is almost obscenely impossible to do. That kind of thing, you're going to want a helicopter there. And even then, you may still not get them in there in 30 minutes. For your history taking, investigate your chief complaint, which is what your patient actually called you for or what you were called out for if your patient's unconscious. Get your medical history. Be alert for injury-specific signs and symptoms. And be aware of any pertinent negatives such as no pain or no loss of sensation. If you're dealing with somebody that got hit in the head, another pertinent negative would be vomiting without nausea, right? So if they're just throwing up without warning, they don't feel nauseous, you don't see them kind of showing any previous signs or anything leading up to it, that's a sign of a head injury. Get your sample. What does sample stand for? Signs and symptoms, good. All right.
Allergies, medication, provocation.
All right, good. What's P?
Last oral intake, events leading up to the incident.
Good. And then what's P? The P in sample. Past medical history, good. And pertinent at that, not just past, right? We only want to know what applies to the situation or what might apply as a risk factor. In not the ARES risk factor. All right, so the whole risk factor thing, Crystal, what they're saying, they're actually trying to change the acronym to be SIMP, so that they're putting an R at the end of it, and that's going to be the risk factors. Yeah. Wait, what are you talking? You thought somebody said all of what? You can unmute if you want to, Crystal. Oh, somebody did say, I didn't catch anything past the P though. I think it was Donna.
Yeah, that's all it was. Like, I thought somebody said all of the samples, so I was just reminding that how you said now they do the R as a risk factor as well. That's all. It was just like a reminder.
Yeah. Yeah, they're trying to put it to sampler. It's additional knowledge. There's not going to be anything that would trip you up on the registry, but it's not. They haven't put it into the registry curriculum yet. That's a lot of your NA EMT stuff has got that, which means in a couple of years your future EMT students are going to have it as well. All right. So for your so yeah, you'll get your sample history. Attempt to gather from friends and family if your patient's unresponsive. Um, Obviously, if they're unresponsive, you're not going to get any symptoms because they can't tell you. So you'll only get signs of the injuries. Information may be obtained by someone who is knowledgeable about the patient, and information may or may not be accurate, and it may be incomplete. So if you get it from somebody else, um, sometimes you may have to take it with a grain of salt. Sometimes people will just plug the dots and try to connect them as best they can, and they'll make stuff up because they think that's accurate about their patient. Um, if it's something about an allergy, take it, I would say, err on the side of caution. If it's something about what they were doing, take that with a grain of salt, especially if somebody wasn't there to actually see it themselves. For your secondary assessment, you're going to do your head to toe here. Um, and when we're dealing with the head and the neck, as we talk about when we get through this, you're going to actually check all the different portions. You're going to start with the cranium, make sure that you don't have any bone movement. You don't want to feel any fractures, any movement. A grown person does not have fontanelles. If you feel something you can press down on, that's a problem. That's a break in the skull. We're going to check each face feature individually. So you're going to check your eyes, your nose, your mouth, your ears, cheeks, check the jaw, all that stuff. And then you're going to move on to your neck. So when you're doing your assessments with us, I want you guys to do that way. Don't just be like, I'm checking the head. What do I see? I'm going to be like, you see a head. All right. I want you to be specific. So say you're checking the cranium. I'll tell you what you find. And then when you get to your face and your ears, check each thing: eyes, nose, mouth, ears, and then move on. All right. But at this point, you're going to be doing your DCAT BTLS. So deformities, contusions, abrasions, punctures, burns, tenderness, lacerations or cuts, and swelling. That's what you're looking for. Don't delay transport to do this. If your patient's in bad condition, just do a real quick head to knee. Make sure you can roll them, get them on a board, load them up, and then go. And you can actually get the more detailed assessment later on. In a responsive patient who has an isolated injury with a limited mechanism, consider focusing your physical exam on the actual injury, right? So if it looks like everything is below the knee and there's no sign of head trauma or anything that would throw you for a loop up there, then just focus on what you see. It's okay if somebody says they sprained their ankle, it's okay not to poke and prod on their head, right? Because that's not what the problem is. Ensure that control of bleeding is maintained and note the location of the injury. Inspect the open wound if there is one for any foreign matter and stabilize impaled objects. It's just like we tell people in lay terms, like if you stab yourself with a pair of scissors, don't remove it. We don't do it as EMTs either because if they weren't bleeding before, let's say that whatever object is impaling them is still holding back the blood loss. If you remove it, suddenly that blood is going to just come out and it winds up taking surgery to fix it. So we stabilize in the field. You stabilize your patient, you stabilize anything that's sticking into them, sticking out of them, and you get them to a hospital. During the physical exam, use both your eyes and your hands because, like with tenderness, for example, you can't see tenderness. So you're going to have to kind of figure that out by pressing, seeing what you can feel. You won't necessarily see distension. So if you're poking on the abdomen and you come across a spot that's distended, you will find that because you poked on them, not by looking at it. If your patient's responsive, you should explain exactly what you're doing and what you're looking for. And I'll take that even further. You should do that when they're unresponsive as well, because they may be alert to their surroundings and just unable to verbalize anything, unable to move, depending on what got hurt. They may have lost the ability to interact with you, but they can still hear you. They can still know what's going on. They may just be paralyzed. Assess all underlying systems. So for your neurologic system, including the brain and major nerves, you can find that out by checking their pupils. You can also get if they're awake, you can see if they can feel you pressing on their feet. Can they move their feet? That kind of thing. Sensory organs, like the eyes and the nose, see if they are functioning. A lot of that just comes down to asking your patient, can you see me? Can you breathe through your nose? That kind of thing. Respiratory system, that's your mouth, nose, sinuses, and airway. Circulatory system, we all know what that is. So focus on the carotid arteries and the jugular veins. The biggest concern for your circulatory system is going to be at the face, or I'm sorry, at the neck, because we want to make sure they get good blood flow to and from their brain. When evaluating your eyes, start with the outer aspect and work toward the pupils. So when you shine the light in their eyes, basically is what they're saying is start at the outside of the head and bring your light toward the nose, cross the eye that way. That way you're guaranteeing you're not accidentally shining the light into both eyes because you want to see that other eye respond. Visual acuity is considered the vital sign of the eye, so ask them if they can see as far as they normally can. Is it clear? That kind of thing. Cover one eye and hold fingers up at arm's length if they can see and see your hand. If they tell you they can see just as clearly as far away as they normally can, then that's a wasted effort. I wouldn't bother with it. But if you can't trust them, and let's say that you think they might have LOC, just ask them if they can see your hand out in front of them. Note any discoloration of the eyes, any bleeding in the eye or any redness, and look for eye symmetry because asymmetry indicates a possible brain injury, referring to your pupils. Determine whether unequal pupils are caused by physiologic or pathologic issues. And that comes down to you asking them. So if when we talked about that disease earlier, it's not really a disease, but if they have that condition, you might want to know that. Otherwise, you're going to be looking at unequal pupils, going, okay, we got a head injury, and then treating it there. If you just don't know, or they're unconscious, err on the side of the injury and treat appropriately because it's better to do the treatment and not need it than to see it and actually think, oh, well, I'm not going to do it anyway, because then negligence kind of plays in. Brain injury, nerve disease, glaucoma, and meningitis are all possible causes of unequal pupils. So get a good history. For your vital signs, assess your vital signs to obtain the baseline so that you can observe any changes during treatment. If they took a bad enough hit to the head, they're going to be an unstable patient. It's usually the case because even if they're not unconscious or an altered LOC, you still have to worry about their airway. So get your vital signs, get that baseline established, and be ready to do it often, especially the vital signs that have to do with your primary assessment. You may be concerned with visible bleeding and unseen bleeding inside a body cavity. There's not a lot of room in the skull. The brain cavity has to have a certain pressure at all times, and so if they start bleeding into that cavity, they're going to be building pressure, and eventually the pressure is going to get so bad that the brain and everything can go only one direction, which is through that foramen magnum at the base of the skull and into the spine and into the spinal cavity, which is called a herniation. And if they herniate, it's going to kill them. So if you're worried about bleeding inside the skull, time is not on your side. Get into a hospital. And we do have a chapter on TBI, so we'll talk about that more. What to look for, some good classic telltale signs that you can see just from across the room sometimes to know, holy crap, we need to get him in the truck and go. All right, use your monitoring devices. Let tech work for you. So use your O2 sat. If you have access to a monitor with a paramedic and they hook it up, it's okay to get a blood pressure using the NIBP. But I would say get your initial baseline. Use your regular equipment. Use a normal blood pressure cuff and stethoscope to get your first set, just in case the computer is not picking it up right. All right, and then for your reassessment, like I said, it's just like always, you're going to reassess every 5 minutes if they're unstable, every 15 minutes if they are stable. Check any interventions you did, make sure their airway is still clear, make sure they're not bleeding anymore if you had to stop any massive bleeds. Double check their JVD. So In these cases, I want you to start assuming JVD or jugular vein distension. Check that like you would check a vital sign. Every time you check their vitals, just look at the side of their neck, see if you see their veins starting to distend out. If you start to see that swelling, um, that tells you that they're starting to have some problems with their cardiac system based on the trauma. And there's not a lot we can do about it except drive faster. But if that's what you see, that is worth telling the hospital ahead of time because they need to get a team together that can do a quick surgery to relieve pressure on the heart and try to get that blood flow going again. And even for you as an EMT, if you see JVD, chances are you're going to find fluid in the lungs pretty soon. So that's going to be something that you need to deal with. If they have JVD, go ahead and grab your bag valve mask because even if you're not already bagging them, you're probably going to want to use it to push fluid out of the lungs. And that's going to become your fight for the rest of the trip. So, like I said here, recheck your interventions, communicate, document properly. Um, any call you go on may have the risk of being called back into court, even if you're not the one on the stand, like being the defendant. You still want to have all your ducks in a row if you ever get called up there. All right. Take a 10-minute break. We'll take a little bit more. Be back at 7:10 and we'll continue out. We're actually getting pretty close to being done a little bit. We're probably like 2/3 to 3/4 of the way done with this chapter. It's a short chapter as far as what we are talking about because we're basically just doing your assessment. So you'll get a lot more of this at the boot camp. But take 10 and some change. Be back 10 after, and we'll continue on. All right, guys, let's go ahead and get back on track here. So we're going to start talking about emergency care, what we're going to do for these kind of injuries. Soft tissue injuries are soft tissue injuries. So basically, you're going to treat them the same as anything else. If you're bleeding from the face or you're bleeding from the arm, your job is to control the bleeding. But we don't want to forego their ABCs. So always ABCs first, get through your primary, then deal with the bleeding. In the absence of life-threatening bleeds, the first step is to open and clear the airway, right? ABCs. The patient may need frequent suctioning of blood draining into the throat. You may be sitting there with the suction the whole time. Sometimes that's just the way it goes. Avoid moving the neck in patients with suspected C-spine injuries unless you have to. If it's, life comes first, and then worrying about the C-spine comes second. Use the jaw thrust maneuver to open the airway and then suction the mouth. And once the patient is immobilized, you can turn the backboard to one side to allow blood or vomitus to drain from the mouth. We usually call this the left lateral recumbent position, but you can turn them in any direction you need to. If their left side is injured at the hip, we don't want to put pressure on it because then we could cause more internal bleeding. So you can roll them to the right. That's perfectly fine. Control bleeding by applying direct manual pressure with a dry, sterile dressing. There's a couple of exceptions to this. First of all, if they have a jacked up face as far as their bones are concerned, and you're worried about pressing into the skull cavity or pressing in a way that shuts off the airway or something, then just don't press as hard. So don't put any excessive pressure on underlying skull fractures. And if you're dealing with anything other than skin, on the face, so like let's say they're bleeding from the eye socket or something, then you're not going to want to use a dry dressing. The eyes, the mucous membranes, that kind of stuff, you're going to want to use a moist dressing for. Um, the dry is mainly for like if they cut their cheek or their forehead, that sort of area. Apply ice locally to injuries that don't break the skin. Again, we talked about it in the past. Ice will constrict blood vessels. It'll stop bleeding. It'll also cause the muscles to tighten up a little bit. It'll reduce swelling. That's what you're going to use your ice for. If you're worried about um, muscle cramps or anything to do with the muscles as far as tightness, heat is good for comfort. Ice is good for controlling blood loss and those sort of things. If you have any injuries around the mouth, make sure you check on the inside for any bleeding that they may aspirate, especially if they go unconscious. Broken teeth and lacerations to the tongue may cause profuse bleeding and obstruction of the upper airway. If they get hit in the face, and they for whatever reason they bite their tongue, um, depending on how bad it is, if they actually severed the tip of it, they could choke on that. The amount of blood loss from their tongue, they can choke on that. The swelling of the tongue itself, especially if they go unconscious, they can choke on that. So you can see how almost all of this has to do with maintaining their airway. Physicians can sometimes graft a piece of avulsed skin back into the appropriate position. So if it happens, just like any other avulsion, don't remove it. Just kind of stabilize it in place. Get them to the hospital. Sometimes they can fix that. If you find portions of avulsed skin, wrap them in sterile dressing, place them in a plastic bag, and keep them cool. Treat it like an amputation. If somebody cut their finger off, we would do the same thing with the finger. You'd put it on ice, keep it cool, deliver it to the emergency room with them. You can keep it on the patient, but don't be like, hey man, here's your finger. That's probably a good way to freak somebody out. But just, let them know, say, hey, we have it. You obviously know you lost it. You're looking at your hand. We have it. And hopefully the doctors may be able to put it back on you at the hospital. Don't tell them that it can happen, because if you're wrong, they're going to come after you for that. But just let them know that that possibility is there. Never place tissue on ice directly, because freezing will destroy the tissue and make it unusable. If you're ever going to do this kind of thing with either an amputation or an avulsion, what you do is you take one Ziploc bag, put a little bit of water in it, put the tissue or the finger or whatever it is, the piece of skin, into that bag, seal it up, put that bag in another bag with the ice, so that you have that cold is there, but you're not directly on the ice. and that's the easiest way to do it. Label the bag with the patient's name and what the just in case it's not recognizable, you can label what it is and deliver it with the patient to the emergency room. If the skin is actually still attached, but it's like a loose flap, then place the flap in the position that it's supposed to go in. So, fold it back over, whatever, and then secure it that way. Hold it in place with a dry sterile dressing. All right, so now we're going to start talking about actual parts of the head, parts of the face, and what we'll do for these. Injuries to the eyes. Eye injuries are common, even though I say that your face doesn't have a lot of protections to it, but some objects do. Your eyes, if you've ever actually looked at somebody, like if you take your palm flat out and you try to hit your eye with it, you're going to catch your orbital bone. Your bone is just a little bit anterior to your eyeball normally, unless you have a condition. I forget the name of it, but normally your eyebrow comes a little bit further out, your bone does, so that if you were to hit yourself in the face there, if it's a wide enough thing, your bone protects your eyeball a little bit. But obviously puncture injuries, something sharp or like a bullet or anything can easily get to your eye. In sports, it happens regularly. People get hit in the head, baseballs. For some reason, football players like to poke each other in the eye. It just it's it's common. These can produce lifelong complications, including blindness. Proper emergency room treatment will minimize pain and may prevent a permanent loss of vision. Um, in a normal eye, the entire circle of the iris is visible. So the pupils around usually equal in size and they react equally when exposed to light. Both eyes will move together. That's why when we're doing our neuro checks and you're looking at one eye or you shine a light in one eye, you're actually looking at the other eye. It's because it should go in tandem. After an injury, though, pupil reaction or shape of an eye movement are often disturbed. So abnormal pupil reactions sometimes are a sign of a brain injury rather than an eye injury. If their pupils are fixed, they're not constricting or dilating, that's a sign of a brain injury. If they're not operating together, that's a sign of a brain injury. If they're just two different things where one's constricted, the other one is dilated, unless it's that condition we mentioned at the beginning of the class, then that could be a brain injury as well. Treatment starts with a thorough exam. Always use your standard precautions. Don't forget your gloves. And with the amount of blood loss you're going to be dealing with, bring a few pairs. Take care not to aggravate any problems. So, do no harm. Try not to make it any worse if you can help it. Look for specific abnormalities or conditions that may suggest the nature of the illness. And a damaged cornea quickly loses its smooth, wet appearance. It can get dry. It can get kind of hazy. When you're looking at it, it doesn't take much to make it lose that nice wet slick look that we associate with normal eyes. For foreign objects, the orbit protects the eye from the penetration of large objects, but sometimes smaller ones, like I said, can get in there. Even a small object may produce severe irritation. Think sand, that kind of thing. The conjunctiva becomes inflamed and red, a condition known as conjunctivitis, which is an inflammation of the conjunctiva, and the eye begins to produce tears in an attempt to flush out the object. That's usually when you're referring to something fine, like I said, like a dust or sand or any of that kind of thing. That's going to be what the eyes are trying to do. Hair. I know we've all gotten an eyelash loose in our eye at some point. Your eye starts watering. It's trying to make it to where it kind of flushes out whatever it is that's on the eyeball. Irrigation with sterile saline solution may frequently flush away loose small particles, but if you're going to do that, be it for just something simple like sand or um, a chemical, if there's say like you're dealing with a chemical injury or something of that sort, positioning is everything. Put the bad eye down so that you're flushing things away from the good eye, right? Let gravity work for you, not against you. If their left eye is the bad eye, you don't want that to be the top, because when you flush it, it's going to run down and into the right eye. So keep that in mind. An easy way to do it to where you can aim, is like the slide says, use a bulb syringe or a nasal airway or cannula. And if you're on a truck, and even if you're not, let's say you work in the fire department and you're, doesn't matter, you can be all basics, you can be EMRs for that matter. Get those saline flushes. They're little 10 cc syringes that are full of saline. We usually use them to flush IV tubes so that they don't have any blood clotting off and sealing up the tube. We'll use it to, if a paramedic pushes meds, sometimes they'll follow it up with a saline flush just to make sure all of it gets into the bloodstream and none of it's hanging out in the IV tube. These are all ALS things, sure, but you can actually use these to flush out eye injuries. You can carry a few of them in your bag, and if you need to flush somebody's eye out, you just open the package, unscrew the tip on the syringe, position their head properly, and then just squirt the fluid in there. 10 cc's a lot of times is enough because you can aim very well with it. A 10 cc syringe is usually enough to get whatever it is out of the eye. Obviously, they're small, so you can pack more if you need more. A foreign body will leave a small abrasion on the conjunctiva. I already said that part. There we go. Okay, it's the right slide. The patient may still report irritation. Just because you get it out of their eye doesn't mean that the damage won't be done. There's going to take some time for the scratches, the abrasions to kind of heal themselves, and your patient's going to report that irritation to you still. It's kind of like if anybody has ever stared at something that's really, really high UV, like say a welder, and you look at that, you look at where they're welding and everything, and it burns your eye, even though there's nothing there, that irritation is still there. It feels like you've got sandpaper in your eye. Every time you go to blink, it hurts. That's kind of the same situation here. If you spot a foreign object on the surface of the eyelid, say it's something big, like a hair or whatever, you can try to flush it. It's usually your easiest way to do it, but if you can't get it with that, you can try to remove it with a moist, sterile, cotton-tipped applicator. Just be very careful that you don't poke into your patient's eye. You're trying, like I said, I don't like, me personally, I have an involuntary jerk anytime something gets close to my eye. I can't do it. Can't even do contacts. If I ever start to lose my vision, I'm just going to be that guy wearing glasses because I don't want contacts. Um, the same thing goes if somebody were to try to come after me with a Q-tip to get some out of my eye, I'm probably going to start getting combative. So just be aware. Sometimes flushing is the best way, and it may even be the only way you have to go. It just depends on what your patient will tolerate. Never attempt to remove an object that is stuck to the cornea. If it's there and it ain't moving, just let it stay there. Let the hospital take care of it. Foreign bodies may be impaled in the eye. The only people that can remove these are the surgeons. Don't try to do it yourself. We just stabilize it and get them to the hospital. The thing about stabilization is remember that your eyes move in tandem. So if let's say they have a piece of wood or like a toothpick or something stuck in their eye somehow, I don't know, hold my beer moment or a bar fight or whatever. What you do is you stabilize that injury, right? So we don't remove it. But when you secure the thing in place, use some of your cling wrap to wrap all the way around the head and cover up both eyes. Because if they're one good eye, if they're trying to watch and see what all's going on around them and that good eye is moving around, so is the eye that's got the object in it. So you want to be careful about that. When we stabilize things, if it's small enough to do so, something that I've done in the past is I'll take like a little paper cup and I'll put it over it, and then I'll secure the cup to the head, and with cling wrap, I'll just wrap around the cup and the other eye, so that they can't see anything. But my wrap is also not directly on the impaled object. That object actually has some room. There's nothing pushing on it or anything of that sort. Cover the eye with a moist, sterile dressing. Surround the object with a donut-shaped collar, if you can make one, or like I said, a cup. Sometimes a little cup will work. Just depends on what you've got on you. But something to stabilize it so that it doesn't move too much. When you see or suspect an impaled object in the eye, bandage both eyes. I already said that. All right, for burns, your role is to stop the burn and prevent further damage. Depending on what caused the burn, there may be nothing to stop. Going back to the welder scenario, the damage to your eye is actually a burn, but it was a burn because they were looking at the slag, um, or the arc or whatever it is, and that it burned them by really high UV. That's not something that lingers. The minute you look away, that burn is gone, but the damage is still there. So stop the burn, prevent further damage. If it's something chemical or of that sort, you may have to do some actual damage control. If it's something caused by light, then there's really nothing for you to do other than supportive care, try to make them feel better as best you can, and get them to the hospital. Chemical burns usually caused by acid or alkaline solution. So if they get lime in their face, if they get any kind of acid in their face, flush the eye with water or sterile saline irrigation solution, and you're probably going to be flushing for something along the lines of 15, 20 minutes. The key word is copious. If you're looking at a test and they say flush it with copious amounts of water, that's the that's the answer you're looking for. Direct the greatest amount of irrigation solution or water into the eye as gently as possible. And you may have to force the eyelids open to irrigate. Your patient's going to be squinting. It's going to be hurting them. They're not going to want to open their eyes because then that just makes it hurt even worse. And so you may have to fight that. And you'll be surprised, just like the jaw thrust, you'll be surprised exactly how strong those muscles are. You ever try to pry a kid's eyes open? Even just a little kid, it's hard to do. You try to do that with an adult, you may have to have somebody specifically for that, where they have one hand on the cheek, one hand on the upper eye, and they're like prying the eyelid open so that you can flush their eye. That's a bad day for everybody, especially your patient. That's a miserable experience. So try to be supportive even in how you talk to them, because it's going to be it's I don't know how to describe it. It's not easy for you. Um, Trying to deal with it, it's really not easy for them. When you flush from the inner corner of the affected eye toward the outside. Again, make sure that's the lower eye because you don't want all that chemical going into their good eye, if they even have a good eye. If the burn was caused by an alkali or a strong acid, you should irrigate the eye continuously for at least 20 minutes. There's where it says it right there on that third bullet. When you are finally done, apply a clean, dry dressing to cover the eye and transport the patient. For thermal burns, during a fire, the eyes will close to protect from heat. That's just our natural reflex. Eyes are frequently burned and require specialized care. If they take actual burns to the face, sometimes you may notice that their skin is melted shut. They may not be able to open their eyes. That's some of the damage that was done to their skin. Eyelids are frequently burned and require specialized care. We cannot do any of that type stuff in the field, so they need to go to a hospital, preferably to a burn center. But you as the EMT, a lot of times you're still worried about stabilizing your patient, so they're going to go to the nearest ER first. And then sometimes they may make it to the burn center. It may not be till the next day because the ER is going to spend probably 24 hours just fighting to keep their fluids in their body. But if you have somebody that was burned to the face, don't worry about doing anything else on the scene. Just throw them in the truck and go. The time is not on your side, not by any means, and they could kill them. So they need to go as quick as they can. Do what you can in the truck. Just don't waste time on scene. If you get out of the truck, you see somebody who burns on the face, you'll be like, all right, let's go. just get them in the truck. You may apply eye shields over the dressing. Anybody that's ever tanned, you know what eye shields are. They basically just help keep light from getting in there. It makes it darker for the patient and it makes it easier on their eyes. They'll still hurt, but they won't hurt as bad. Light burns, infrared light, eclipse. Like if somebody stares at an eclipse, like a solar eclipse, they think that because it's dark, it's not going to hurt them. It's actually misleading. It's like getting sunburned on a cloudy day. It can happen, and in fact, it happens more common because people take it for granted. Laser beams can cause this. Retinal injuries caused by exposure to extremely bright lights are generally not painful, but may result in permanent damage. Sometimes they are painful. It can make it feel like you've got, like I said, sand in your eye. Here I am rubbing my eye because I feel like I got something in it. Superficial burns of the eye can result from ultraviolet light from an arc welding unit, like we were talking about earlier, light from prolonged exposure to a sun lamp, or reflected light from a bright snow-covered area. Up here, we have to worry about that. It's called snow blindness. It's where the snow is reflecting so much light back at us that even if you're looking down, you may as well be staring at the sun because it's so bright. This may not be painful at first, but it may become so about 3 to 5 hours later. Severe conjunctivitis usually develops with redness, swelling, and excessive tear production. And you can ease the pain by covering each eye with a sterile, moist pad and an eye shield. Again, light causes the damage, so if you can get it to where no light can get back into the eye, you're not going to get them down to a 0 out of 10 pain, but you can at least kind of alleviate it. For lacerations, cuts to the eyelid, cuts to the eye. Cuts to the eyelids require very careful repair to restore appearance and function. Bleeding may be heavy because there's a lot of vessels there, but it's usually can be controlled with gentle manual pressure. So if you take a 2x2, which is obviously it's a small version of a 4x4 gauze, and just put light pressure on their eyelid, it'll soak up the blood. It is very vascular. It'll bleed a lot, but it's very small blood vessels, so they'll clot fast if you do some bleeding control there. If the laceration is to the eye itself, don't do pressure. The pressure is mainly for the eyelids. If the eyeball itself has the cut, if you put pressure, all you're going to do is you're going to push that viscous fluid out and you're going to do more damage to the eye. All right. Follow these important guidelines in treating penetrating injuries to the eye. So again, we're talking about impalements. Never exert pressure or manipulate the injured globe. If part of the eyeball is exposed, gently apply a moist, sterile dressing to prevent drying. Again, like I said earlier, if you're dealing with a skin injury, you can use a dry dressing. If you're dealing with something that's supposed to be moist, like a mucous membrane or the eyes, use a moist dressing. On rare occasions, the eyeball may be displaced from its socket. That usually happens when your patient gets hit in the back of the head real hard. A lot of times you may hear somebody say that the eye's been blown out. That's pressure being transferred through the skull and it's popping the eye out. If that happens, it's just like any other evisceration or something of that sort. We're not going to try to put it back in. Just try to stabilize it as best you can with a moist dressing because it's an eye. Cover both eyes so that the good one moving doesn't try to mess with the other one, and get them to the hospital. Have your patient lie supine to prevent loss of fluid from the eye. It just helps a little bit with that. It may be unavoidable to an extent, but it's a little bit that you can do to try to help. For blunt trauma, injuries range from the ordinary black eye to a severely damaged globe. Hyphemia, which is bleeding into the anterior chamber of the eye, you'll actually see that their eyeball, instead of being white, will be red. This obscures all or part of the iris. It's common in blunt trauma and may cause seriously impaired vision because it's getting in the way. Cover the eye to protect it from further injury and provide transport. If you have an orbital fracture or a blowout fracture, this is where the bone that surrounds the eye gets fractured. Place a stretcher and transport immediately. We can't do anything about this. It's going to take a couple of surgeries to fix this, and particularly an orthopedic surgeon because it's their bone that's a problem. You can protect the eye with a metal shield or the little eye covers that we talked about that block out the light. Cover the eye to minimize movement. And then, retinal detachment is on this slide. So a retinal detachment is often seen in sports, especially boxing. This is painless because there's no nerve endings there, so they may not even realize it's happened as far as pain is concerned. But it's going to produce flashing lights and specks, sometimes called floaters. It's just where light is being pushed in different directions. It's not getting caught where it needs to, and they're catching little like flakes of light that they can't see. Is because it's hitting the wrong parts of the eye. They can't focus on it. If this happens, if you're responding to this, same thing. Just get them to a hospital. Any of the following eye injuries should alert you to the possibility of a head trauma. So one pupil larger than the other, which we talked about. One eye not moving together or pointing in different directions, unless some people have the lazy eyes, that's the one thing. But if it's not something that's normal to them, and that's what you see, that's a sign of a head injury. Failure of the eyes to follow movement of your finger as instructed. Bleeding under the conjunctiva, protrusion or a bulging of one eye. Again, if they got hit in the back of the head, that's a big sign of it, is that one of their eyes may have bulged out from pressure. For an unconscious patient, keep the eyelids closed. Cover the lids with a moist gauze and hold them closed with clear tape. Normal tears will then keep the tissues moist, assuming that they're able to do that. For blast injuries, signs and symptoms of blast injuries range from severe pain and loss of vision to foreign bodies within the globe. Think about what your patient's getting hit with. We talked about the primary blast, secondary blast, all that stuff. A lot of things get kicked up. Dust gets kicked up. The primary blast being the shock wave will do some damage. If they get caught with shrapnel, that's going to be in the eye. So you have to consider all that if we're dealing with blast injuries. Before responding to patients after the blast, make sure the scene is safe. There's a thing called secondary devices. That's where your patient wasn't necessarily the target. You're probably the target. So whenever you go into a blast injury, unless it's just a fluke at an industrial site or something, if it's a possible act of terrorism, be on your A game with your scene safety, because the blast you're responding to might have just been bait, and you don't want to be the one that goes in when the second blast is waiting on you. Management of injury to the eye depends on the severity of the injury. If there's a foreign body within the globe, just like before, don't try to remove it, stabilize it. Try to clean it if you can, if it's something that you can wash out. Otherwise, stabilize it and get them to a hospital. Patients with a sudden loss or decrease of vision will have to be verbally instructed on what to do and what's going on around them. So if they can't see, you may have to talk, even if something is happening that it doesn't necessarily have to do with them. If it's just really close to them, tell them what it is, because their curiosity is going to be that they're going to want to try to look. And if they can't see, or if they've got something in their eye, every time they try to move their eyeballs around, they're going to do more damage. If the patient has severe swelling or a hematoma to the eyelid, don't attempt to force the eye open. Just let it be as it is and get them to the hospital. For contact lenses, in general, don't try to remove them. Just let them stay. Let the hospital take care of it. The only exception is if there's a chemical burn, because we want to try to remove the chemical. Those contact lenses will hold the chemicals underneath. They'll also start to fuse to the eye. That's some bad things. So sometimes, depending on where you work, some ambulance companies may put an eyelid remover in your bag. It looks like a little miniature toilet plunger. You just put it on the eye, on the contact lens, and it creates a suction and allows you to remove it. That way you're not trying to use your finger, especially with those gloves on, because you can't really feel with the medical gloves on. It's just a much safer way to do it for your patient. But those are last resort options. It really is only for chemical burns. All right, so that's just an example. It's kind of what you see on the left there is the plunger I was talking about. All right, for nosebleeds, these are common. Sometimes they can be severe, but a lot of people have these and they're really not all that bad. But the biggest issue, especially if they're unconscious, is that blood's probably going to go into their airway. Nosebleeds are further categorized into anterior and posterior epistaxis. Anterior nosebleeds usually originate from the area of the septum, and they bleed slow. Usually these are self-limiting and they resolve quickly. This is what you normally see, like if somebody starts bleeding down their upper lip, that's what these nosebleeds are. Posterior nosebleeds are much more severe and often cause blood to drain into the patient's throat. Attempting to insert a nasopharyngeal airway in a patient with a suspected basilar skull fracture, or if they have facial injuries, is controversial. It's not forbidden, but it's also not something that we just say, oh yeah, do it. If they have an injury of this sort, or if you think they have an injury of this sort, defer to your local guidelines. If it's either that or they're going to suffocate, then screw it, do it. You need to get it. You need to get their airway. Just be very careful. If you meet resistance, don't force it. Pull back a little bit. Rotate the NPA, and we'll go over this at boot camp. But just pull back a hair, rotate, try again. See if you meet the same resistance. If you really are having to press hard, chances are the skull either A, you're going to run the risk of poking through it, or B, it just fractured and it's in the way, and you're not going to be able to get the NPA in. So if you really have to force it, you're doing wrong. Um, and at that point, you can try the other nostril, or just say screw it and not deal with it. The nose often takes the brunt of physical assault. In car crashes, it is the most anterior part of your face. So if you're going to get hit in the head, or at least hit in the face, the nose is going to be the first thing to get smashed. Blunt injuries to the nose may be associated with fractures and soft tissue injuries of the face, head injuries, and/or injuries to the cervical spine. If it's a small hit, like say somebody catches a basketball to the face, um, a lot of times it's just their nose is going to get bloodied, and that's going to be the extent of it. If they get smashed by, the front of their car or a tree, or they get hit by something serious, then now you've got much bigger issues. The nasal cavity is divided into two chambers by the nasal septum. Both chambers have a superior, middle, and an inferior turbinate is how it's spelled here, but I've always said tuberate, which is what you can see there. So once you get into the nose, it actually opens up pretty wide, but you have these little indentions that cause like almost like three different passageways, and it's all still the same. They're not sealed off, but what that does, when you breathe in through your nose, that causes air turbulence, which starts to warm the air up. The whole purpose of that is so that the air, by the time it gets to your lungs, is your body's temperature. That's why you walk outside in 30-degree temps. You don't spaz out your lungs with ice cold air as fast as you would if you were to walk out and start breathing through your mouth, for example. But if you're going to put an NPA in somebody, that's one of the reasons why, as you do it, you're going to wind up rotating that NPA to pass through, is because you're having to maneuver it through those areas. All right. The big issue with the nose is because it's so close to your cribriform plate. If they get hit hard there and you do crack the skull, the portion of the skull that separates the face from the brain, you could lose cerebrospinal fluid. We call it CSF for short. So from here on, I'm fine if you say CSF, but I want you to know what it stands for. CSF may escape down through the nose following a fracture at the base of the skull. If you see this, or if you think you're dealing with this, this is a big telltale sign that you may have a bone fracture that you wouldn't normally see because it's further back in the head. Use a piece of gauze to absorb the blood, and what you're going to do is, if there is CSF fluid there, you're going to see what looks like a halo of yellow around the blood. Something else you can do is, if you have a glucometer and you're not sure if you have CSF fluid coming out of somebody's face, you can do a glucose check on the blood that's coming out of their nose or out of their ears. If it spikes really high with blood sugar, that tells you that you have CSF fluid there. All right, because CSF has a whole lot of glucose in it. So a reading from there is going to be much higher than a reading from, say, their fingertips. Control bleeding by applying a sterile dressing. If the patient is bleeding heavily, it could be the result of significant trauma. So that being said, consider C-spine, right? The patient should not be moved if the airway can be managed in the patient's present position. If you can't manage the airways, say they're prone, for example, then roll them over. If I give you a scenario where your patient is face down, it should be one of your first things to do is roll them over, because you have to get their airway open. For a non-trauma patient who is bleeding from the nose, place the patient in a sitting position, leaning forward, and pinch the nostrils together. That's how you apply direct pressure to seal off the bleed. Don't let them lay back. Don't let them look up at the sky. All that does is it makes the blood go down the back of their throat and into their either their stomach, which is going to make them want to vomit. Um, and it also, you can't, the pressure you're putting on the nose does absolutely nothing if the blood's not going that way, because you're not able to stop the blood and cause that coagulation. All right, for your ears, the ear is complex and associated with hearing and balance. A lot of people don't realize that the inner ear controls your balance. I forget what the actual thing is called, but it's basically a it's a chamber in your inner ear that's got a whole bunch of fine black dust looking stuff inside of it that gravity acts on, right? So if you turn your head, gravity is pulling all that stuff to the side, and where that stuff sits, there's a bunch of sensors that tells your body, all right, this is down. You turn your head up, that stuff moves to a different part of the chamber. That's where the weight's at. Body tells you that that direction is down. That's how you can tell. So you can imagine if you sit in something that spins you around really quick, your sense of direction is going to get really jacked up really quick. If there's any kind of swelling in your ear or an ear infection that starts to affect that area, it can start to mess with your sense of balance. But we divide the ear into three parts. You have your external, your middle, and your inner. Your external ear is the pinna, the auricle, and everything that lies outside the head. All right, so you can, if somebody took another, I know in the Bible they talk about how somebody lost their ear, and Jesus put it back on. Not getting into religion or anything, but that's your external ear. That's not anything that's inside the skull. It's just the part you can actually reach up and grab and tug on. The external auditory canal leads in toward the tympanic membrane, which is your eardrum, and that's what separates your external ear from your middle ear. Your middle ear, there we go. We'll keep it on this. Your middle ear contains three small bones: the hammer, anvil, and stirrup, that move in response to sound waves hitting the eardrum. So as your eardrum moves, it's going to vibrate those bones. The middle ear is connected to the nasal cavity by the eustachian tube, which is the internal auditory canal. So you can see that on this picture. That's the tube that runs down toward the right center that actually goes to your mouth. And that's for pressure equalization. By design, that is so that if you get into like all right, so we fly or you live in a high climate or a high altitude area, when the pressure changes, that is how we fix that. So when you do the Valsalva maneuver, where you pinch your nose and breathe out, or if you get good at it, you can just swallow, and it pops it equalizes pressure through that tube. That's what it's designed for. But something about that I want to point out: when you're dealing with patients with infections, be it an ear infection or a sinus infection, the infection can travel that tube. So let's say you have a patient with an ear infection and they don't like going to the doctor, or they don't realize they have it. That infection can work its way from the ear down to the mouth. Now they got a sore throat. They don't like to go to the doctor. They just, man, I've just been feeling under the weather for a while. They don't realize that they have an infection spreading. Now it gets into their airway, works its way down. Eventually it can lead to pneumonia, and it all started with an ear infection. That's how it spreads, because it runs that tube. Um, But anyway, I digress. That's just something to think about when you have patients who, in the middle of winter, just don't want to get out and go to the doctor because it's cold outside, or elderly patients are susceptible to it because they're afraid that if they try to get any kind of help, they're going to lose their independence. You can see how infections will spread, and I just wanted you to be aware that that's if it doesn't make any sense of how did an ear infection get into your lungs or whatever, that's how I did it. So your inner ear is composed of bone chambers filled with fluid, and as the head moves, so does the fluid. This is what helps your balance, helps you figure out what direction is up and down. In response, fine nerve endings within the fluid send impulses to the brain about the position of the head. That's why if you close your eyes, you can still tell what direction your head is facing, even though you're not looking. Ears are often injured, but they don't usually bleed very much. There's just not a lot of blood vessels there. As you can tell, if you look at this, most of your inner ear is bone. If local pressure does not control bleeding, apply a roller dressing or we call it cling wrap sometimes, just depends on what you're using. In case of an ear avulsion, wrap the avulsed part in a moist sterile dressing and put it in a plastic bag labeled with the patient's name, just like anything else. If you rupture your tympanic membrane, which can happen in blast injuries, this can even happen in concerts, right? Just a high decibel really loud speaker. If somebody is at a concert and they're standing right next to one of those massive speakers, it can cause a ruptured eardrum. Um, just sometimes, if that happens, and this is what you're dealing with, your patient may report severe pain, difficulty hearing, or ringing in the affected ear. Sorry, my Siri is trying to go off on me. Um, and this may be caused by an insertion of objects too far into the ear. So I can remember very clearly, even though I'm about to be 38 years old, and my mom was trying to tickle my brain with Q-tips as a kid. Just, she's like, hold still, I got to clean your ear. And I'm like, well, if you want to clean my left ear, take it out of my right ear, please. You don't have to go in that way. Um, patients with a suspected tympanic membrane injury should be transported to the hospital for evaluation. Children place foreign objects in their ear. I have never seen that nor done it myself. Usually, like I said, my mom was the one to stick crap in my ear. But all foreign objects should be removed by a physician. You just don't want to cause any damage. Don't try to manipulate the foreign body. You may push it further into the ear. Treat it like an object in their throat. If you can't see it, don't reach for it. Even if you can, really just, it's not causing any harm where it's at. Just let the doctor take care of it. Clear fluid coming from the ear may indicate a skull fracture. That's your CSF fluid coming out. So if that's the case, and again, you can check the same way. Like I said, you can use a glucometer. You can take a 4x4 bandage, just put it up to the ear, look at it. If you see what looks like a little halo ring around the blood, then that lets you know that the CSF fluid is there. And yeah, I see that. A lot of parents do. They're like, hold still, I got to clean your ear. That crap is painful. If your kid fights you on it, I definitely understand because I did. Poor kid. I get it. I get it. You tell him I feel his pain. All right. Facial fractures um, typically result from a blunt object. So, like I said, usually we try to. I resort to things like car wrecks to be the examples for this, but a lot of times you're going to really see this more in domestics. If somebody is using an object like a piece of wood, a fire extinguisher, I have seen. In fact, there was that attack in Florida that happened at a nightclub a couple years ago where the guy got his face bashed in with the base of a fire extinguisher. That kind of stuff can do some massive, massive damage, and that's what we're referring to what I want you to think about here. I don't want you to think about somebody that got hit with a basketball. That really doesn't do anything. But getting those kind of hits that will literally break your face, break the bones, you should assume that any patient who has sustained that kind of a blow is going to have a facial fracture, and we're not just talking about a busted lip. So other clues include bleeding in the mouth, inability to swallow or talk, absent or loose teeth, or a loose or movable bone fragment that's not supposed to move. Remember, the only movable bone by design is your mandible. So if anything else is moving, that's because they broke their bones, and that's a bad thing. They are called Lafort, Lafort, Lafort fractures, and they're named after the doctor that found them or that classified them. Depending on how bad it is, that could be a Lafort 1 through 3. Actually, I think it might be 4 levels of Lafort fractures. But anyway, the bigger the number, the worse the break. Facial fractures alone are not acute emergencies unless there's a serious bleeding. Um, you're more worried about their ABCs at that point. Let's see. My son got punched in the face by a perp and broke his jaw in 3 places, both sides and in the middle, right below. Jesus, 5. Yeah, right below the gum line. Wow. 5 hours to fix his mandible. Did he have any other? Just on a quick tangent. Did he have any other damage? Any damage to the maxilla? Um, or was it all just on his jaw? That's one hell of a hit. Maxilla and well, yeah, okay. So both upper and lower jaw wired shut for 6 weeks. Ooh, that's no bueno. But yeah, I mean, that's what I'm saying. Like it's a sad thing. You would think that, or I wish that people only got hurt by accidents, but yeah, no, the violence from one to another can cause some major issues. So plastic surgeons can repair the damage to the face and the mouth if the injuries are treated within 7 to 10 days. After that, some of the natural healing will make it a little bit too hard to deal with. Um, Remove and save loose teeth or bone fragments from the mouth because it is often possible to replant them. Remove any loose dentures or dental bridges to protect against airway obstruction. But if you have to breathe for your patient, don't remove it. Let those dentures stay there because you need that firmness to create your seal with your mask. If you remove somebody's dentures, you're not going to be able to create a seal to give them a good breath. Another source of airway obstruction is swelling, which can be extreme within the first 24 hours after an injury. Dental injuries can be traumatic to the patient if they lose teeth. And I want to say this about that too. It's probably going to be in here because I know this in the American Heart Association's first aid. Um, they had this weird, and I call it a home remedy, but I mean, if it works, if you got it on hand, great. If you want to save somebody's teeth, we talk about like when I told you about your amputations earlier, putting it in ice water. They actually say to put teeth in milk. And now I don't, if that's, I guess it's for the calcium to keep the tooth healthy and everything, but I don't know. If you don't have milk, don't waste time looking for it. Just get them to the hospital. Anyway, dental injuries can be traumatic to the patient. The injury may be traumatic, and the patient's permanent teeth may be lost. Um, and this can affect everything from eating to smiling. Again, we use our face to communicate a whole lot more than we use our actual words. What your facial expression says a lot more than what the words say. So when we have these injuries, these can be pretty significant. Bleeding will occur whenever a tooth is violently displaced from its socket. So apply direct pressure to stop the bleeding, perform suction if needed, cracked or loose teeth or possible airway obstructions, especially if your patient is starting to lose consciousness. Save and transport an avulsed tooth, handling it by the crown. Don't grab it by the root. Um, it's just if you do that, the risk of them being able to, or the chance of them being able to put it back into place go way down. Place the tooth in storage solution. If you can use cold milk, great. Otherwise, just use saline. Um, Notify the receiving facility of an avulsed tooth because they're going to need to call in dentists or whatever. I'm kind of dumb when it comes to that field. If it's orthodontists or I'm not sure which ones do it, but they need to be there for that. Um, Reimplantation is recommended within 20 minutes to an hour after the trauma. So if you're going to try to save the tooth, get them there pretty quick. You may encounter an object impaled in a patient's cheek. If you do, all I really want to say with this is just leave it, stabilize it in place, unless it's going to cause a problem with their airway, in which case, yes, go ahead and remove it. Make sure that when you do try to bandage it, don't do so in such a way that blocks their airway. That should be common sense, but Most people, sometimes they'll get tunnel vision. They're like, we got to stop this bleed. Um, at some point, the bandage will become more of a threat than the blood will. So just keep that in mind. Injuries to the neck. So again, we talk about those three things. You want to look for your step off, your tracheal deviation, and your JVD. But these are the different kind of injuries that you may see. So if they get hit here, you have damage to the upper airway, the esophagus, your carotid arteries and jugular veins, the thyroid cartilage, which is your Adam's apple. Cricoid cartilage can get damaged in upper parts of the trachea. If it's blunt injuries that are hitting them, any crushing injury or on the upper part of the neck is likely to involve the larynx or the trachea. Some examples would be like hitting the steering wheel. Attempted suicide by hanging is going to cause issues here. Clothesline injuries sustained while riding a motorcycle, if they even manage to keep their head intact in the first place. I've seen people get straight up beheaded by this. But the least damaging would be that they hurt their neck. Once the cartilage of the upper airway and larynx are fractured, they don't heal. They don't spring back into their normal position. And as with any cartilage, there's very little blood flow. There's not a lot of veins there, so it's going to take forever to heal. This can lead to a loss of voice, difficulty swallowing, severe and sometimes fatal airway obstruction, and leakage of air into the soft tissues of the neck. Subcutaneous emphysema is a characteristic crackling sensation produced by the presence of air in the soft tissues of the neck. So if you hear this like snap, crackle, pop, especially when you press, you put any kind of pressure on the skin, that's what that is. That's air that's been leaking out of their airway and getting into that area. If you feel this when you palpate the neck, maintain the airway as best you can and transport immediately. Complete airway obstruction can develop very rapidly, so be prepared for that. ALS needs to be there. Get them as quick as you can. Call a helicopter, call the cavalry, whatever you got to do, because very likely they're going to need an ET tube or some kind of advanced airway that you're not able to do on your own. It is possible that these injuries and incidents involving the throat may also have cervical spine injury, so you have to put a C collar on them. But I will say this, when you're dealing with this, fix what you can with the neck before you put the collar on, because if you don't, you're going to have to remove the collar, and then now you're going backwards in your assessment, which does you no good. Give me just a second. Okay, yeah, we're almost to the end. I know it's normally your break time, but I don't know how many slides we are, but we're only about 2 topics away from the end, so I'm just going to press on, and then we'll call it a night here in a few minutes. For penetrating injuries to the neck can cause profuse bleeding from laceration of the great vessels, right? So your carotid artery, if that gets severed, you're talking massive, massive bleeding that can be life-threatening very quickly. So we want to try to take care of that as quick as we can, and not just the artery, but the vein too. Your jugular veins are not far from your heart. The jugular veins are pretty big. Injuries to these large vessels may also allow air to enter the circulatory system, which is a massive problem because that's going to cause air embolisms. If a vein has been punctured, air may be sucked in and sucked through to the heart. This condition is called an air embolism. Am I on the right slide? Yeah, I am. Okay. A large enough amount of air in the right atrium or right ventricle of the heart can lead to cardiac arrest, and it's sudden. Their heart will that'll be it, because it's not able to move any more blood. The airway, the esophagus, and the spinal cord can be damaged by a penetrating injury. Like I said, your esophagus usually is protected because it's right down the middle. Your airway sits anterior to it. You have your sternocleidomastoid muscles to the sides, your spine to the back. It's pretty well protected, which is weird because you would think that that's like the least important thing, but that's just by design. That's how we are. Direct pressure over the bleeding site will control most neck bleeding. All right, and we'll show you how to do that when we get to the boot camp. You may find it necessary to apply pressure above and below the penetrating wound to control life-threatening bleeds or to stop air getting in. That's fine. Do what you need to do. Just try not to put, if it's a, let's say it's a massive bleed to the carotid artery. If you do apply pressure, don't do it to both sides. If you have to occlude one artery, try your best to make sure the other one still functions. Maintain C-spine if indicated. Right. For your laryngeal injuries, blunt force trauma to the larynx can occur when an understrained driver strikes the steering wheel, snowmobile rider, or an off-road biker. You guys down south, four-wheelers, three-wheelers, motorcycles, that kind of thing. If they get a clothesline injury where they catch a tree branch or a wire, that kind of thing, that can cause damage to their larynx. The larynx becomes crushed against the cervical spine, resulting in soft tissue injury and fractures, and sometimes it will completely separate. Um, these strangulation injuries can also be found in either intentional or unintentional hangings. One of the last calls I worked at the base down in Belchase was a hanging. The guy had actually managed to hang himself from his pull-up bar in his closet. His feet were on the ground. He still was successful in his suicide attempt. It was the weirdest thing I'd ever seen. Usually you think people hanging, not to get morbid, but you when you think of a hanging injury, you think of somebody that's hanging from a high area where they climbed up on a chair or something of that sort. But they don't have to. They can do this damage with their feet never leaving the ground, because once they pass out, that's it. It doesn't matter that their feet are on the ground. Um, Anytime there's an injury to the larynx, same thing, suspect possible cervical spine injury. Penetrating or impaled objects in the larynx should not be removed unless they interfere with your CPR. So if it's there, leave it. If you try to remove it, it may cause more bleeding. The only time that's going to change is if you're trying to do CPR and it's in the way, then you can remove it. Otherwise, just stabilize it if it's not obstructing the airway. Signs and symptoms, or, well, I'll just say signs, that pose an immediate risk of airway compromise. You have respiratory distress, hoarseness, pain, difficulty swallowing, which is dysphagia, cyanosis, they're starting to turn blue on you, pale skin, sputum in the wound, subcutaneous emphysema, bruising on the neck, hematoma, bleeding. And to manage a laryngeal injury, just provide oxygen and ventilation if you need to. Apply C-spine and avoid using rigid collars, just because it's going to get in the way. All right. You don't want something that is going to be pressing on that Adam's apple if they have an injury there. So if you have a soft collar, you may have to makeshift one from your bed sheet. We've done that before, where you just take a sheet from the ambulance, roll it up, and have it wrap it around their neck like a donut. It just does a better job of not putting more pressure than what's needed on their larynx. And that is it. Not bad. We're only 5 minutes overdue from what would have been a break. Any questions on tonight? Most of it's just regular bleeding control. The only thing is just remembering about the damage to the airway. Do what you need to do to protect the airway. Worry about CSF. If you have that injury, you want to be careful with the NPAs, because you don't want to put it into the brain cavity, but it doesn't mean you can't give it. Just be careful with it. Don't try to shove it in. If you meet resistance, back up, rotate it a little bit, try again. If you still meet resistance, especially significant resistance, then just pull it out. Don't worry about it. But it is at least worth the effort. Any questions while I pull up your PIN number for the night? Yes. All right. So the blood glucose reading, you can do that in place of the halo test. It does take a little bit longer. The problem is if you need a significant amount of CSF to do the halo test. If there is not much of it there, you may not see the halo. So you could miss a fracture that's not leaking a lot of CSF out. But if there is CSF in the blood, the glucometer will tell you it's going to give you a much higher reading than normal, like a much, much, much higher reading than normal. So if you've already got it, you can set your partner, tell your partner if you're worried about it, say I'm going to have my partner do a quick glucose reading of the blood coming out of the nose and the mouth, just to check. They could be doing that while you continue your assessment. Good question. CSF stops blood from clotting normally too, as well. Normally, right? It doesn't really stop it. The reason that I don't want you to think of it as a blood thinner, at least. So if CSF is in the blood, the problem is it waters it down. And so just physically think about that. Your platelets are going to be further apart. They're going to have more of a medium they have to get through to clot onto each other. So it could slow it down. But it's not that it's really going to stop the blood. It's just going to make it take longer. That was also a good one. Any other questions? All right. All right. Well, if there's no other questions, your pin for the night is going to be Bravo Charlie 27 Foxtrot, BC 27F. There you go. All right, guys. Well, I hope you had a great Thanksgiving. Oh, wait. What about addressing the issue of someone with a wired jaw and blood? If they have a wired jaw, you should still be able to get a suction in. In fact, if they wire a jaw shut, they usually have to leave enough room for that, because the inability to move your jaw like you want will affect your ability to swallow. Um, you may have to use a soft suction. A hard yanker may not fit, but it's better than nothing. And a soft suction will get blood. It won't do anything for an object like a tooth, but by the time they've wired it, um, you shouldn't have that issue. And yeah, it'll be a challenge. Which, like I said, especially with your son, you know it's not fun, and it's not easy. How long, if you don't mind me asking, how long was he dealing with that wired jaw? 6 weeks. Damn, 6 weeks because he's had to eat through the tube too. Um, yep. 6 weeks in, you're pretty good at it. It's probably, I don't know, what was it like when they finally did take the wire off? I imagine that was, yeah. Oh, by the way, I'm going to stop the recording. Class is done. I don't think there's any other pertinent questions.